focusing especially in terms of driving organizational change. Reason being that a lot of time, we do a lot of quality improvement as small projects. So they are very siloed as we go along. What does it take to move it all the way to an organizational strategy so that consistently we build what we call a culture of quality improvement? Next. Okay, so I will basically be focusing on how to influence quality improvement and support for organizational learning, because the whole concept of improvement science is about organizational learning. That is basically what it is. So I'll try to demystify this whole animal. But I know for most of us who are already practitioners, researchers in this area, it's not very new, but at least it will allow me to reflect my thoughts, and then we can probably have a discussion. Next slide. Yes, so what is important is that quality improvement in itself ultimately has to be a culture. Now, if something has to be a culture, it is actually a journey. Because by the time it becomes a culture, it means that a collective group within that organization or that unit basically do the things unconsciously. It's like the way we drive. You know, you will brake unconsciously because something is probably crossing you on the road. You will probably honk to alert somebody who is probably obstructing you on the road. However, probably before you started driving, it wasn't quite the same. Sometimes you even forget that you probably have to step on the accelerator or the brake pedal, you know. So culture is basically what it is, but it's a process. It starts with knowledge. Unfortunately, for most of us, when we start learning about quality improvement, we think we are there. That is just the first step. All the concepts you learn and so forth, the tools, that is just knowledge. We have to then move it to skills. And moving it to skills is where mentorship and coaching comes. You know, skills is being able to practically apply. So once you apply consistently, then you move to the next phase of what we call habit. Habit is when a core group of people or individuals basically understand it, apply it in all types of contexts and circumstances. And they do it. But at that point, it is still not organization-wide. So that is still not the ultimate. Culture is where you want to get to. So it is a journey. For some people, it might happen reasonably quick. For others, it might even take years. And for a country, sometimes it is like we are still not there. You will be hovering somewhere within the journey. Next slide. Okay, so I would just want to go back a bit to let us reflect a bit in terms of our understanding about quality. Because perhaps over my last 15 years in quality improvement in Africa and other parts of the world, it is probably the most what would I call it? It's probably the most confounding term in terms of how people understand it and how they relate to the whole concept of quality. But I want us to look at it in the context of total quality management, so to speak. Can we go one slide forward? Somebody mentioned this. I used to use this slide as far back as 11 years ago when we were training HSDF staff in Lagos. I was one of those who trained those teams in Lagos, the team. And we say that, yes, we all have technical definitions for quality. If you look at Institute of Medicine's, definition, you look at WHO's definition, if you look at all the other countries that have adopted it, there are 6 principal dimensions that you would see being exhibited in those definitions. But for everybody who becomes a patient, or anybody who is not really technical, what does it really mean? And we always say there are 3 things. We've already elaborated about this. Number 1, I'm coming with a situation, heal me, solve it. Number 2, whilst you are healing me, don't harm me. Is that not the case? So patient safety and all those issues come in that umbrella. And then, of course, be nice to me. So we talk about customer care. Now we are even talking about customer experience, not just patient-centered care. We are moving to customer experience, which we've talked about already. Let's move on. Next slide. Please, previous slide. I think you jumped it. Yes. So for us to conceptualize quality, I think it is important that we compartmentalize it. So I always say that there are 3 core elements. And the reason why I use this figure of a stool, a 3-legged stool, is because no one part of it is quality in itself, and no one part of it stands alone. They are all fused together. So you cannot do quality improvement as we know it if you don't have the quality planning and what we call the assurance or assessments as another vital component that you build on. So it is going to be very critical. And this is basically what Durand wrote in a lot of his work. He's describing it as the Durand trilogy. It is very fundamental. Let's move on, please. Next slide. Now, next slide. In this whole concept, you know what the planning is. Planning is all about, putting all the elements together, right? Human resource, equipment, infrastructure, policies. So it is more about the setup of the system. So if it were a computer, we'll call it the hardware. All the components, the hard drive, the processor, and so on and so forth, the lens, the touchpad, and so on and so forth. So this is basically setting the system. Okay, that is the planning part. Then we have the control, quality assurance or control, or even assessments. That is more about the standards. So there are standards that regulate professional practice for the various professionals. There are standards that also regulate the way we do things. So all the protocols, the standard treatment guidelines, all those ones are in that area. We utilize a lot of them in quality improvement. However, those are just things that you do. In fact, one of the most surprising things to me is I've gone several places, especially in the past, where they confuse quality improvement to be quality assurance. So they go and inspect something, and they take a checklist. Oh, this is not there, this is there, this is your mark. You don't have that, you have that, this is where you are. And that to them is improvement. And they say, oh, you go and work hard. Tomorrow or next 6 months when I come back, let's see where you will be. That in itself is not improvement. The improvement part is where you will then go down based on the assurance part where you know where your baseline is. And there is a specific way we collect baseline in quality improvement. And I believe Lauren, in her keynote yesterday, mentioned that. The quality improvement data is quite different from how we look at traditional data. So it is very important. And I know most of us practitioners are kind of aware. So we set aims, very ambitious, however realistic aims, based on the sense that we will redesign the system. We will institute indicators or what we call measures. So that whatever we do, we will be able to track on an ongoing basis, week-by-week basis, month-by-month basis, even sometimes daily, day-to-day basis, on how we are going towards that goal. Then we will then have to find a way to deploy a set of tools that will help us to establish what are the changes that we will do that will result in an improvement. All this process, together with testing with something like a PDCA cycle, you understand, through the planning, the doing, the studying the results, and then taking a decision, okay, as whether we abandon and so forth, goes into that area of improvement science. And that's why we always call it CQI, continuous quality improvement, because it is a continuous process. Next slide. Now, if you look at the gaps, I don't want to talk so much about gaps, but if you look at these two slides, this is a slide I took about universal health coverage for various regions. So we are looking at sub-Saharan Africa on the left, and on the right is Western Europe. You get it? So in any case, when we are doing quality improvement, we have to understand that there is a gap. It is the basis for which you want to close the gap. That is why we call it improvement. In this case, we can see that this indicator that is stated there, as at 2020, with the end of 2021, looking at where we are in terms of the SDG goals, we are 47, sub-Saharan Africa. Another continent, Western Europe region, is 88. So clearly, we can say that in that respect, our gap is what? Bigger than maybe another place. But we can see that we are trending in a certain direction. And there are various projections in terms of which direction we might go, depending on what we do. Will we go higher by 2030 to 58? Are we going to go at the current trajectory to 54? Or we are probably even going to slack? Because if there's degradation in terms of performance, we probably will not even hit 49. That's the reality. Next slide. So gaps in quality improvement, when we are doing quality improvement science, basically fall into 4 categories. I like to call them the Olympic rings. First category is what we call quantity. In healthcare, we know quantity is what we call coverages, right? Scale delivery coverage, pathograph use coverage. Anything you hear coverage, it means you are looking at a quantity of service that is required and whether you are able to meet that quantity and what is the extent. So a simple percentage computation will give you the quantity, right? The second one is what we sometimes call the quality. Now, quantity, because quantity in itself is an element of quality. You get it? Because if you do so good, so very well in terms of quality for just one out of 8 people, then you cannot claim that you have done quality, right? So you want to increase your scope in terms of who you need to do the service for. But quality, in terms of, to make it less technical, I would say is the content of the care. For whatever care process is required, we know what to do. We have evidence from research. We have evidence from practice over time. We have updated that evidence. We have standard treatment protocols. To what extent do we really give the care to that required standard? So depending on where we are, we can measure the quality thereof. You understand? And then, of course, in terms of reliability, it just basically means whether we are able to provide a high level of quality all the time to whoever needs it. How many of our health facilities, for instance, can operate very well on Mondays, but on weekends, basically, it's just not happening? How many of our maternity wards operate very well optimally? We are doing pathograph use tracking or pathogram tracking with midwives on the clients who are in labor. However, maybe in the night, you have fewer midwives and you have more load, and they cannot do all. So you begin to see gaps. That is not a reliable service. You understand? Imagine your phone, your network. If it will work the whole morning, and then by afternoon, when you are trying to call somebody, it doesn't work, how would you feel? That is basically reliability. So the question is, all these services we provide, can we say they are really reliable? That is critical. We need to measure. So that is also a gap. Sometimes we forget. And of course, client-centeredness. Now we are even calling it what? We should call our clients guests, right? So healthcare, I don't think is doing great. We have a lot of complaints from people who are in labor, antenatal care services, or even people like myself. When I go to the hospital, sometimes I'm not happy. So we have all kinds of issues around that. The question is, can we benchmark the hospitality industry when it comes to client-centeredness? Can we benchmark aviation industry when it comes to reliability? Because if we do, there's a lot we can learn. Next slide. Now, this is what we call the traditional system of introducing interventions or policies or changes. I've just summarized it so that it makes it easier. We start with the boardroom at the top. A group of people who are experts, maybe at the ministry, or maybe senior management. They sit down based on the data they have on their hands, or based on some survey they have conducted. They basically begin to, think through it and then come up with a plan of how to solve a problem, right? Which is divorced from those who are actually implementing a lot of those interventions at the bedside, so to speak. So they design, and they say, okay, we are going to do it, and we start doing it. Usually, when we get to the stage of implementation, we might have some challenges in the real world. And more often than not, we don't succeed as much as we thought we would. And then we begin to struggle. Oh, we need more doctors. We need more vehicles. We need more fuel. You understand? Then you train more doctors, you train more midwives, and the results don't quite move. That is the traditional system. Next slide. So essentially, this traditional system creates a gap. This is a slide that my boss, Dr. Soji, when I was working on the Project 5's Alive, the IHI project that happened in Ghana between 2007 to 2015, he used one time, and it basically summarizes what it is. The problem in quality improvement is not that we are so bad. Yes, if you look at it today, we probably are doing on the green line. We are doing better than what we did yesterday in the past. So we are making incremental changes. And most likely, if we go forward, we will do better than what we are doing today in the future. The question is, the evidence exists. Research is emerging all the time. Evidence exists that we can do much better. Because much as we are doing on the green, if you look at the blue, in the past, the gap was there, but currently, the gap is becoming wider. As we go forward, it will even become wider. This is the reality. The job of improvement science or quality improvement is to close this gap. Not to know more and be able to achieve little on the ground. It's to close the gap between knowledge, what we know, what evidence has, and what we are able to do. Next slide. So what does it take to improve quality? So let's go to the improvement. What do we mean by improvement? What does it take? First of all, we need to understand that improving quality is about creating, in fact, in this conference, in this session, we say intentional, right? Intentionally. That means you are going to create it, not by accident, because you've thought about it, you know what to do with it, and you want to create a certain situation, which is the desired outcome. Next slide. And usually, most of the things in terms of what we want to improve are things around improving the system within which we work. We want to reduce harm in the case of patient safety. We want to improve clinical care, effectiveness of care, right? That's the quality issues that we talk about. And then we want to engage and empower patients, their families, and the communities that we work in, right? If you look at it on a non-technical level, this is basically the summary of what we want to achieve. Next slide. However, I think this is a very profound definition of quality improvement. Okay? If you look at Gibbons, Batalden, and then Don Berwick, former IHI president and CEO, they wrote a paper that they published in '94, and they described quality improvement as the organized creation of beneficial change, and that it is the attainment of unprecedented levels of what? Of performance. That for me is profound. I've seen a lot of definitions, and most of us have encountered a lot of definitions. But for we those who are practitioners, for we those who have been in the space, especially in Africa, clearly each of these words are not random. It has to be organized. How do you organize it? You have to create it. It shouldn't be by accident. It has to be beneficial, because sometimes you do certain things and you get relatively bad performances. How do you remedy that? And that you have to get to a stage of your performance which you have never had before. It means that you have to change the system. And that is why we talk about systems analysis, systems and systems. And I recall Lauren again mentioned a lot about systems yesterday. I would not even belabor it. I think we had a good dose of that. Next slide. Now, what are the core elements? If you want to improve quality, for you to do it in an organized way, as described in the previous slide, first of all, you have to think about a strategy. Now, you have to grow from the strategy and then utilize the method. The method is the vehicle. The strategy is the roadmap. The method is the vehicle. And the strategy could be at the macro level. So, national quality health plans. We talked about some we did in Ghana. We've done some in Liberia, Sierra Leone. There are a whole lot of places that a lot of that has happened. I have been part of it, doing a lot of this type of work. For the Ghana one, we were actually the organization who worked with IHI to develop the Ghana one, where that was launched in December 2016. But method is important. By what means are you going to give practical expression to that strategy? What do you need to do? What are the things you need? You need a set of tools. You need a method to be able to take you there. And that's where we will go to. Then you need to get to culture. Culture is your destination. Remember my second slide when we started. Okay, next slide. Okay. And it is important that for you to do this journey, there are three elements. Again, it's like triangle. Will, we call it that you have to build will. Number two, what do you have to do? You have to have ideas. Ideas. And then number three, you have to make sure that you have an execution mechanism that would work, that would deliver, whatever you want in terms of your culture. I will not talk much. I think a lot of things have happened around this, but I will just pick excerpts of them and then maybe give you a practical experience in terms of what those things mean. Next slide. Okay. So usually when you are building will, building will does not mean that once you are the manager, you are the authority, you just go and say, this is how we are going to do it. Because wherever you are going as an organization, you have to have a vision that is measurable, that is realistic, that should drive the whole agenda. And you have to carry everybody with you. So you have to carry it at the various levels, right from leadership to the departments, to the front line, and even involve your patients. There are various categories of people. And it has to be communicated that there is a uniform understanding in terms of what we want to achieve. That is very significant. Sometimes what a manager thinks is the vision or is the will to do whatever they want to do. When you go downstairs, maybe to the person at the front side, at the bedside, they don't quite understand it. That already is a disconnect. So building will is important that all the key stakeholders are involved. Next slide. Now, if we did this, we will then go to deploying a strategy, which I call the quality improvement way. In this way, yes, whatever we are deciding to do, it is not decided by just senior management at the board. It goes all the way down based on the stakeholders I've listed. So we all go to the boardroom, we design together. And when we design, we don't assume that it's going to be perfect. We have to go and try it out. So we do a small trial. So we go into the real world, and that's why we test using the PDCA cycle. As we test, we are building a body of evidence in terms of what works and what does not work. And what works is what you modify until the time where it works in every circumstance with everybody who is familiar with it. In that case, you then go ahead and get management mandate or approval to say that, okay, this is what we are going to do because it works under every circumstance. At that point, we say we are implementing. So everything else before then is a testing to build a body of evidence. And then we implement. And that is only when we are likely to achieve success. Because remember, what might work in region A or in province A might not work in province B. What might work in facility A might not work in facility C. Because there are contextual differences, culture of the people, even people's religion, ideology, even staff motivation, numbers, resources that are available, even the level of the facility. Is it a tertiary facility? Is it a primary facility? These dynamics come into play. So you have to tweak and test and modify to get to that point. Next slide. So what do we mean? We say that it is not enough for you to go with your subject matter knowledge. Oh, I'm a pharmacist, I'm a pediatrician, I'm a biomedical scientist. Oh, we have the midwives, we have the nurses. We've gone to all those professional schools and we have the best, and we think that we are doing good work in the facility. That is not enough. Again, we have to go into what we mean by profound knowledge. For some of us who have read a bit about improvement science, you know that Deming wrote a number of books, 2 of which are the New Economics, and then the other one is Out of Crisis, in which he espoused a lot around improvement science and what it means to do to what he calls profound knowledge, which is basically 4 components. A lot of that was dealt with yesterday, so I'll not go into those details. Understanding variation, data, how to understand data, how to analyze. Somebody talked about Pareto analysis, the previous panel. You understand? Pareto analysis will reveal how you prioritize and which are your key drivers that you need to focus on. You know, you want to be able to determine whether a change is an improvement. So you want to put it in a run chart and see whether you are getting, you know. So there are a lot of elements on that. You need to understand systems, which is one part. You need to understand how to use the PDCA cycle to build a body of knowledge, which we call experiential learning. That is also part of that part, profound knowledge. And then, of course, you are going to work with people. People have different motivations. They have different backgrounds. How do you mitigate your limitations, and how do you optimize your strengths within a team context? Because quality improvement is not a one-man champion. It's a team effort. And the teams, those who are even most critical to the teams, are those who are closer to the bedside, who are closer to the patients, because they are the ones who impact directly on care. Okay, next slide. Next slide. So what does this mean? More often than not, you go into certain spaces and people get confused because people have different methods. Somebody says, I'm using model for improvement. Another says, I'm using Kaizen. So there are a lot of them. The issue is that they all aim in different ways to do the same things. To cut out waste, to optimize a system to perform, and not necessarily with additional resources. That's basically what they do. So whichever one you are familiar with, remember that it helps you to organize and create beneficial change. It helps you to get unprecedented levels of what? Performance. Remember. But in this case, I know most of us are more exposed to model for improvement. And that becomes the method. So that becomes the method for what? Taking ideas and testing them in a real setting, and then generating knowledge, gaining confidence, and implementing the changes that will lead to an improvement. And then sometimes we deploy improvement collaboratives. When you have a lot of facilities involved, you want to be able to track, you want to be able to do shared learning, you want to be able to impart knowledge, give quality improvement knowledge and expertise, right? So that you can guide people. And that's how you grow people into the knowledge. But the knowledge is not theory. I remember when I was doing the Improvement Advisor Professional Program in 2009 with IHI in Boston. We paid $15,000 for it, each of us. Now, there are some of my colleagues who did that training over the period of the 10 months and never really got to practice. They were probably at the boardroom, you know, allocating resources. But I happened to work in over a total of over 2,000 facilities, leading quality improvement with them. So what I learned in practice is quite different from the person who just learned in theory. And I think this is important. It is important because quality improvement is more of, the results you get in quality improvement is not too much of a theory. The theory is just the knowledge. But what happens on the field, which is the skills and the habit, is what really impacts results. So how do we move it from a theory-based approach to a practical approach? Sometimes when you use equipment for collaboratives, especially when a number of facilities are involved, it becomes an excellent methodology. We call it a learning system. You know, it's a strategy that we can deploy. For some of us, I'm sure some of us are familiar with it. Can we go to the next slide? I think I'm trying to wind up. Now, what is important is that improvement capability. Sometimes I don't like to say capacity. Capacity is like knowledge, right? You want to know. But, anybody who has done anything about human beings or psychology, human psychology, will tell you that human beings are a product of what? Habit. We are not a product of knowledge. How many of us agree? We humans are a product of habit. We are not a product of knowledge. So if you go to any place and you think that people know, and so because of that things will be different, no, it doesn't work like that. It is the habit. That's why we say that it's not knowledge, it is what? Culture. So you have to go through that. So the question is, for you to create that habit, you need to create a menu of the things that you will teach people. At what level? What kind of mentorship? You have to segment. The ones that you do for every staff, for instance, in your organization, cannot be the same as the one you are doing for the coaches. The one you are going to do for your senior management on your board cannot be the one that you are doing for the coaches. In fact, they will not even have the time. Oh, they should go and do an improvement project. They don't have the time. You understand? They don't even have time to go for meetings and allocate resources and manage the organization, right? So there's a difference. So it is carefully calibrated, and you target a certain type of improvement capacity building or capability building at various levels. What should everybody know in your organization? What are the ones who will be part of the teams? Who are the representatives of everybody? To what extent should they know? What are the programs we can develop for them? And those who are going to be leading the teams on a day-to-day basis, how much more should they know beyond every other team member? Clearly, those ones you know more about data, collecting the data, creating tools, and so forth. And then when you go to people like the leaders, they want to see performance. How do you track performance? What do you show them? Because they want to use that information for decision-making, to allocate resources, right? So what is the kind of information they need? How can they interpret that information? That is the knowledge you need to give them, And then, of course, there are sometimes where we say deep quality improvement expertise. So Arum Institute, for instance, is an expert because they have been doing a lot of quality improvement work in the Southern Africa and a lot of other countries, right? So they have developed experience to a level that maybe in your hospital, you might never get that experience. I, who work for Ubora Institute, having worked with IHR as well over the period of 15 years, I have developed some type of expertise in quality improvement science that if you sit in your facility, just doing quality improvement work in your facility, you might never have that depth of knowledge. So usually, there's another level of knowledge that you need that you can go and get some expert to do that. Okay, I think my time is up. I'm just about 2 slides to go. Can we go to the next slide? Okay. So with all these being done, for quality improvement to stay in your system, just to conclude, 1, you need to make sure that you embed a lot of all these gains. If you have the gains now done with all these building blocks, you've measured, you have a system that is running, embed it. Scale it up, because maybe you started small in some departments, or in some districts, or in some provinces. Can you scale it up across the organization so that there's learning? Okay? And can you create a change package so that people don't have to reinvent the wheel? What you have learned in terms of what works, can you just suggest? So that's why we say in quality improvement, we copy what? Shamelessly. You understand? And adapt, and then we spread. And that is how you can create a systems-wide performance that really drives changes. Next slide. Next slide. Next slide. So this is what you achieve. And I will just show you some results that we did from the Project 5's Alive work that IHI did in Ghana, that I worked on it for 6 years. And you see what results we got at the end. Can we go to the next slide? And that will be my last slide. Next one, the last one, the one with the graphs. Yes. So this is it. So I wanted to make a case that if you do all these things, you can get results like that, which you call what? Unprecedented levels of performance. Remember, if you don't get that, and you don't change the system like never before, you probably are still not there with quality improvement. I will leave it here. Thank you very much.